Hey everyone, welcome to Baltimore County Fire Department EMS Academy. For those who I haven't met, my name is Sean Barinholtz. I am an anesthesia and ICU physician at Hopkins. I am an active volunteer at Pikesville Volunteer Fire Company, and I have the honor of serving as one of the associate medical director in Dr. Pollock's office for Baltimore County Fire Department. On behalf of Dr. Pollock and the EMS office, on behalf of the EMS office, Director Shenning, Captain Stewart, Captain Fitzpatrick, thank you for what you guys do every day. Thank you for your dedication to lifelong learning. A big shout out today to Ashley Brooks. Ashley is a volunteer at Pikesville. Ashley is helping us with our IT platform. Ashley is also the one who will put in the chat a link that you can click on the link, enter some information and get your CEUs. So if you want your CEUs, keep an eye out on the chat. We will also announce when Ashley puts the link in the chat. Click on the link. Fill in some information and get your MIMS CEUs. So tonight, I'm delighted to have with us Dr. Chimene Richa. Dr. Richa completed her ophthalmology residency at the University of Maryland. Early in her training, she decided she enjoyed working with patients who had problems of the tissues surrounding the eye, specifically the eyelid, the tear drainage system, and the bones of the eye socket. She completed an Oculoplastic fellowship, and in her practice, she sees patients with a range of eyelid problems. Dr. Richa, thank you for being with us. Thank you for being willing to go down into your basement to escape the toddlers, to have some quiet, so you can share with us what you know. Thank you. We really appreciate you.
Thank you very much, Sean. Thanks for having me. I'm very happy to be here to talk to you all about ophthalmology and eye emergencies for EMS providers. This is, informal setting. Please ask questions. Sean is going to go ahead and moderate. If you type your question in the chat, he will interrupt me and ask the question. And I will also have time at the end, open to any eye questions, any and all eye questions, whether emergency or not. Anything you've had a burning desire to know about when it comes to the eye. All right, we'll get started. So the objectives for tonight, we're going to go through basic eye anatomy, very basic stuff, a basic ocular exam skills that you can do when you are seeing a patient with the stuff you have in your kits, nothing fancy. Talk about different eye findings that you may see, that you may come across. So that way, if you do come across them, it won't be the first time you're seeing them. And help these different eye findings can help you triage in your mind, what you should be doing with this person, what kind of potentially serious condition they might have. And then lastly, we'll talk about what eye emergencies will require transport to a facility with ophthalmology versus something that could just go to, the closest ER. So like I said, we're going to do anatomy, exam techniques, and exam findings, and then we'll move on to eye emergencies. So this is an eye, very simple stuff, just to review the nomenclature of how sometimes we'll refer to different things in the eyes. The pupil, you all know, the iris, the colored part of the eye, the medial canthus over here, and the lateral canthus. The canthus is just where the two eyelids come together. So the medial canthus is the side near the nose, and the lateral canthus is the side closest to the temple. The sclera is the white part of the eye, and it's the part of the eye that actually gives the eye its structure. It's the firm part that holds everything together, and that's what makes the eye feel like an eye. And then it's covered with the very thin membrane that's not labeled here, but all these little blood vessels are in a very thin, clear membrane called the conjunctiva. That's what turns pink when you get pink eye, conjunctivitis. And then, that's what you see the blood vessels, et cetera, from the outside. If you were to take your eye and then cut it so that you can see what's going on the inside, you can see here's the cornea. That's like a clear dome that covers your iris, which is the colored part of the eye. And remember, the pupil is just a hole in the iris. It's just the iris is a muscle that opens and closes, and the pupil is just a hole in the middle. The lens is behind the iris. And then behind that, you have the bulk of the eye. This is the vitreous cavity. This is what holds the jelly that's in your eye, and that's what keeps your eye full. That's what makes it a grape and not a raisin. That's what gives it its sort of tension. In the very back of the eye, kind of lining the inside of this, I don't know if you want to think of it like a water balloon, like lining the inside of it is your retina. And your retina is an incredibly thin layer of neural cells. And all of these cells, they collect all the light that comes through the pupil, and then they send it along the optic nerve, which is kind of like a coax cable that connects the eyeball to the brain. They sends all those light images, the light signals to the brain. The brain interprets them, and then that's how you see. That's what gives you vision. When we talk about retina, there's also a special part of the retina called the macula. And it's this little tiny part of the retina here. And here they just did an inset so you could see the fovea is this little divot. The fovea is the center of your macula, and that's where you see 20/20. So you're looking at that eye chart down at the end of the room, you're seeing 20/20, that's your fovea. The macula is responsible for your center vision. So reading, writing, computer work, cooking, using tools, most of what we do in our day-to-day lives is due to our vision in our macula. And when you have a problem with your macula, as in macular degeneration, that can cause a lot of hardship for people, because then they can no longer see what's in front of them. Interestingly, most of your retina is devoted to your peripheral vision. So if you think about it evolutionarily, as we were evolving as a species, we needed to be able to see that, jaguar or whatever jumping out of the trees coming at us, more than necessarily seeing the fruit that's in front of us. Our vision has developed that most of our retina is devoted to all of that peripheral motion, but the center part of our vision that we would feel is the most important is actually a very small part of your retina. So moving on to examining the eye, it's not a tricky thing, but it can be tricky for people because a lot of people are just not comfortable around the eye. They're not comfortable, touching the eye or getting close to the eye. It can be sometimes kind of an intimate situation when you're like all up in someone's face. And if you are uncomfortable or nervous or wigged out by whatever it is you're seeing, patients are like cats, right? They can smell fear. They know you're not happy. They know you are not sure what you're doing, and that's going to make them more stressed out that you're supposed to be taking care of them and you're not comfortable with whatever it is you're doing. So just developing the confidence to know what you're talking about, to know what to do, to know what you're seeing, and then know who to tell and how to tell it can just go a long way to making the entire experience more comfortable for everybody involved. The tools for a good eye exam are really minimal. You have all of them at your disposal. You have a bright light source of some sort, your cell phone, your pen light, your flashlight, whatever. You've got something. Obviously, you've got fingers and eyes. And then, if you want extra bonus points, you can download a vision app, a vision chart from an app on your phone. Really not necessary. From an evaluation from someone coming off the ambulance, if you tell me their vision is 20/50 or 20/30, really doesn't make a big deal than if you told me, they can't see anything at all, or they can only see my finger. So it's up to you on how detailed you want to be with the vision exam. But there are some tricks to do a good vision exam that will give you the most amount of information in the least amount of time. I know you don't want to spend hours and hours trying to get someone to read these little tiny letters at the bottom of a screen, but there are some tricks that you can use to just make this whole process easier. First of all, if they wear glasses, if you come in and you see like reading glasses next to them, have them put them on, because all it's going to tell you is it's blurry without their glasses. So if they, if they say my vision's blurry, do you wear glasses? Yes. Is it blurry with your glasses on? And you would be surprised at how many people say, oh no, it's fine when I have my glasses on. Okay. So ask them about the glasses, test one eye at a time. And people are our brains are very good at compensating for left and right when it comes to the eyes. So if you can completely lose vision in one eye. I mean, completely blind and not know it, because your other eye is still seeing all of the world. I've had patients where I've had to unfortunately remove an eye. They do totally fine. They can drive, they can do all sorts of things. So you can be completely functional with no vision in one eye, but also you may not realize you don't have vision in one eye unless you checked. So check when someone comes in and you see either facial trauma or their eyes look funny or something that's going to draw your attention to the eye. check the vision in each eye individually. When you're checking vision, like I said, when we do it in the office and it's a routine situation, we have a chart at the end of the room and, start at the big E and work your way down. And then if they can't do that, we start getting closer. In your situation, you're the reverse. You're doing it in an emergent setting. You want to just get an idea of what can they see and how much can they see and can they see it all. So you're going to start with light perception. Can you see my light? Yes, great. Can you see my hand moving? HM is hand motion. Yes, great. Okay, I'm going to show you some fingers. How many do you see? I see one. I see two. Okay, great. Once you get to that point, then if you like, there still seems to be a discrepancy in one eye versus the other, you want more information. You can do that by just moving your fingers further back. So you can have count fingers at 6 inches right in front of their face. You can hold your arm all the way out and say, count fingers at 3 feet. Your partner can stand 6 feet away and hold up their fingers and see what they can read. If that person is count fingers at 6 feet, well, then they didn't go blind from whatever just happened. You get a sense of, okay, there's some decent vision there. And if you need to go further, you can pull out your smartphone app and try to go a little bit more granular. But you got a really good sense of, what, they're only light perception in this eye, but I got them counting fingers at the end of the room in the other eye. I can tell there's definitely something wrong. So, what sorts of abnormal findings might you find when you're checking vision? Other than the patient saying, oh, my vision's blurry. Well, the vision could be worse in one eye, or the vision could be worse in both eyes. And there's a big difference in terms of the kind of pathway your brain's going to go down in terms of what am I going to do with this patient? What am I thinking about? So if it's worse in one eye, so clearly only one eye is affected vision-wise, then the pathology has to be either eyeball or optic nerve. And that includes eye socket, like if there's something in the orbit that's pushing on the optic nerve. But that's where the pathology has to be. If it's worse in both eyes, it has to be a intracranial process. And the reason is, if you look at this image here, you've got left eye, right eye. If you imagine these two lines together are the optic nerve. So you've got optic nerve. This is the chiasm, which sits right around the pituitary in the brain. Once it passes the chiasm, you get fibers from both eyes. So this brain tissue over here has fibers from left and right eye, as does this side. So once you get into the brain, you cannot only knock out vision on one eye, in one eye. It's just not possible because of the anatomy. So if there's a vision problem and it's only one eye, it has to be before the chiasm. It has to be eyeball or optic nerve. There's just nothing else it can be. And then if it's both, it has to be the brain. You can't hit someone's optic nerve and get something on the other side. They just, if you look at the anatomy, they just don't connect that way. Another abnormal finding you might get when you check someone's vision is distorted vision. This is not common, but it could happen, especially in someone who maybe had said that they were complaining of flashes and floaters, and then they saw a shadow or a curtain dropping, and then now their vision is very distorted or something like that. When you have a distorted vision, that is usually a retina problem. It's generally not painful, but that very thin layer of cells that line the inside of the eye, they need to be absolutely flat because they need to make all those neurologic connections so that the light can travel to the brain. If there's a space, like if the retina billows up because of liquid getting under the retina, or retinal tear in setting of trauma, or retinal detachment, fluid can get underneath, and now the light is not going where it's supposed to. So one test we use in the clinic is we have them, there's a little black dot right here. We have them focus on that black dot and we ask them, do all the lines and squares look straight up and down, left and right, as you would expect on graph paper? And someone with a retina problem will say, no, it looks squiggly. It looks all like scrunched up and distorted. And you can actually locate where in the retina there's a retinal problem based on, we can have them draw. They will actually draw on the paper, this area is distorted, and that will correspond exactly to which part of the retina is having trouble. Not likely something you'll see. you'll most often just get vision worse in one eye or vision worse in both eyes. The next part of the eye exam is extraocular movement. This is very easy, very quick, if you do it right. And the only real trick to doing it right is, other than, you're going to draw an H in the air. So like that, and you can see on this cartoon here, when you're going up, down, left, right, you essentially are going to have those eyes moving in all those different directions. And here you can see the examiner standing in front of the patient and he's watching her finger. The trick is you have to hold the patient's head still. So what I got into the habit of doing is, if I'm going to use my right finger to make the H, I use my left hand on the person's forehead, because otherwise they do this, and that's not very useful, because then they're not moving their eyes, they're moving their head and their neck. So you want to stabilize their head and then have them follow that finger. And what you can do, what you'll see is you'll see this. You'll see them moving their eyes in different directions. And by doing that, you look and you make sure, are they moving together? Step one, are they moving together? Your eyes are always supposed to do everything together. The pupils are supposed to move together. The muscles are supposed to move together. The lids are supposed to move together. So if they do this and it looks completely normal, you're done. Like no further delving into extraocular movement is necessary. However, you may find some abnormalities. You may see that maybe one eye doesn't move as well as the other. And so they're not symmetric in all gazes. You'll say, hey, oh, that's funny. When he looks over there, it's not the same, but when he looks over there, the eyes are together. Or they may try and go out, oh, no, I can't look that way. It hurts too much. That's another exam finding, that there's something that is affecting their muscles. It could be bone, it could be inflammation. It's giving them pain when they try to move their eyes around. Or they may complain flat out of double vision. Someone complains of double vision, it's usually because their eyes are misaligned. And so when you do that test, you may be able to pick up which eye is misaligned, or how are they misaligned? Does it look like they're crossing or going outways, or is it only when they look in certain directions? And, most of the causes of an abnormal eye movement are going to be neurologic. Trauma can certainly do it, especially if you have bony trauma. Once you start cracking the orbit and messing things around, well, then the eyeballs themselves are going to be misaligned, and that's going to make things not look symmetric at all. Certain drugs can mess with your eye movements, but most often it's going to be things like strokes, increased intracranial pressure. MS can do it. And with the strokes, it's, you can have your stroke, like your big stroke, the stroke that's the scary stroke that, ends up with admission to the hospital. But you can also have a stroke to a single nerve. So the eye muscles are innervated by cranial nerves. So these are nerves that come directly off the brain. And in some cases, they may only innervate one muscle or just a few muscles around the eye, and that's all that they do. So some people will have strokes where all they did is knock out one eye muscle. And when that happens, you get an imbalance of the two eyes. They don't move together, and the person develops double vision and abnormal eye movements. Increased intracranial pressure can also cause this because of the anatomy of how these cranial nerves run from the brain to the eye muscles. Specifically, with increased intracranial pressure, it's the sixth nerve. Because of the way it runs in the middle of the sinus. And so when the brain fills up with blood or with fluid and everything starts putting pressure on that sinus, it hits the sixth nerve harder than the others, because the other ones are protected by bony parts of the skull. Whereas the sixth nerve is just sort of floating in the middle of the sinus. So when you build up that pressure, it just squeezes the nerve and knocks it out. Now, when you reduce that pressure and you treat it, it usually comes right back. It's not necessarily a permanent damage. And same thing with the strokes. A lot of times people will recover from cranial nerve 3 palsy or a stroke or a cranial nerve 6 stroke, but some people may not recover 100%. But the point is, you can have a stroke that only affects one little tiny nerve as opposed to, a big chunk of brain. So here are some examples. So this top picture, this guy's looking, if you were talking to him, you're looking straight ahead at him. you probably would be like, oh, I don't know, maybe a lid's a little droopy. I stare at lids all day, so I notice droopy eyelids a lot. But for the most part, I'm not super impressed. I don't really notice any problems. There's no redness, looking fine. This guy looks to his left, looks completely normal. He looks to the right, and whoa, right? This eye, the left eye, is completely normal. It's looking all the way to the right as it should. The left eye, it just stops. It won't go past midline. And you can imagine he's got a lot of double vision in this view because his eyes are basically like this. They're not looking at the same part of the world at all. This is a sixth nerve palsy. So the sixth nerves, its job, it has one job, and it innervates the lateral rectus muscle. So the muscle here, and there's a sixth nerve on this side that innervates this muscle here. This sixth nerve is working fine because he can look all the way laterally on that side. This sixth nerve is not working. He can't look all the way to the right. So he's got a right sixth nerve palsy. Now, why? Well, that's going to depend on what else is going on. Does he have a lot of cardiovascular risk factors? Does he have other signs of increased intracranial pressure, etc.? This picture here is someone who's, you can tell they've had trauma. You see bruising, you see blood. There's some blood on the conjunctiva. This one looks relatively normal. So if we look at this one, clearly the person is trying to look up. This eye is doing fine. This eye is not. And you can imagine in this view, when they're trying to look up, they probably have a lot of double vision. What they also have is they probably have pain because in the setting of trauma, trying to look up like that and not able to most likely means that there's an orbital floor fracture. And what's happened is the bone has broken and probably the muscle that's down here is stuck. It's being tethered to the fracture. So when your eye tries to look up, it just can't. It can't get that far. And so you get a pulling sensation. It's uncomfortable for the patient. And clearly they're not able to look up all the way. This photo here is a third nerve palsy. And this is considered more emergent, more urgent than the others, for the reason that in a lot of people, a third nerve palsy is a brain aneurysm until proven otherwise. So this person needs urgent care, and it needs to go to an appropriate institution that can do the right imaging, not just, most ERs now have everything, but and what gives us away is several things. The third nerve, unlike the sixth nerve, innervates a lot of different parts around the eye. It does the eyelid. So the third nerve is what holds the eyelid open. So if you knock out the third nerve, that eyelid is going to drop. The other thing is you can't see his eye well because his lid is closed, but you can see it's right here. It's not, this one's in the center and this one should be in the center, but it's not. It's down, it's kind of down and out. And that's because the third nerve is responsible for many of these other muscles. And so the only ones left that are working are pulling the eye down and out. And if you were to pick up this lid and look at his pupil, you'd see it's probably mid-dilated. And that constellation of symptoms is a third nerve palsy, which is an aneurysm until proven otherwise. So visual fields, that's the next eye exam that you can do. And the way you do it is just how you see it in the picture. You sit in front of your patient and you want to line yourself up. And you can see here, the practitioner is covering her right eye and the patient's covering her left eye, but they're both looking at the same part of the room, right? So if you imagine they're looking at the part of the room that's closest to us, they're covering the part of the room that's closest to us and they are looking at the part of the room that's closest to that desk. And the way you can do this easily and successfully is, first of all, you need to have the person look at your nose. Because as soon as you start putting up fingers, they're going to look right at their fingers. And all that's going to tell you is that from their center vision, they can see your fingers. Well, at this point, you would have already checked their vision. And if they can't count your fingers back in the beginning, you're not going to be checking their visual fields because they couldn't count your fingers at the beginning. So you know that they can count your fingers. What you want to do is they can see it out of their peripheral vision. So you want to make sure they're always staring at your nose so that you can evaluate the side vision. And the other thing is you're using yourself as a control. So the reason these people are kind of lined up the way they are is so that the practitioner can be staring at the patient's nose and using her own field to say, okay, well, I see that I have two fingers here. Let's see if the patient sees it. And then she can test here. and she can test here and here, and she knows what she should be able to see. And so she knows what the patient should be able to see. I mean, if I have my hand like all the way back here, I can't see it. So the patient's not going to be able to see it. So you can use yourself as a control to make sure you're not holding your fingers in an area that no one's going to be able to see. And then staying focused on their nose and having them stay focused on your nose will keep it so that you're not essentially wasting your time by checking their vision again. And what you want to look for is, are they full in each quadrant? Can they see your fingers in each quadrant? And if they can't, you know, that is usually a sign of, you know, something going on in the brain, especially if it's on both sides. If it's only on one side, then it's probably something going on in the optic nerve. And here's another illustration. This is just illustrating some visual field issues, but just so you could see again the anatomy, the eyeball, the optic nerve, and here's the chiasm in the brain where the fibers start to cross. So you can see here that if you knocked out something right here at A, only the right eye is going to be affected. The left eye is going to be completely normal. If you knock out at B, you're actually going to hit both, and you knock out at C, you're going to hit both. So anything at the chiasm and beyond is going to affect both eyes. So anything in the brain is going to affect both eyes. Okay, pupils. I know you're all probably very familiar with checking reactivity, with looking for, you know, the blown pupil, asymmetric pupils. We're going to talk at length about a peaked pupil, but I really want to talk about, when you're looking at pupils, doing the swinging flashlight test. And the purpose behind the swinging flashlight test is to look at the function of the optic nerves of each eye as compared to each other. And what I mean is, if you think about the way your eye functions in response to light, you shine a bright light, you know, you have a normal sort of baseline. You shine a bright light and both optic nerves register. You just shine a flashlight in their eyes and both pupils constrict, and they should do so equally. You take that flashlight away, you go into a dark room, and you see that both pupils dilate. Both optic nerves sense that the amount of light has dropped, so they need to dilate to get in as much light as possible. And if you have a problem with one optic nerve, you won't be able to pick it up if all you're doing is checking to see if the pupils are reacting to light. Because let's say an optic nerve is 50% busted, you know, something, a stroke knocked out 50% of the optic nerve. Well, when you shine a flashlight into that eye, that's 50% is still brighter than the room. So it's going to constrict. You're still going to have reactivity. But the swinging flashlight test will show you how one side is acting different from the other. And I'm going to pull up a very short video to illustrate what's happening with the swinging flashlight test, and then we can talk a little bit more about it. Let me know if the sound doesn't come through.
Here, the normal pupils constrict briskly, then relax a little. They dilate again after the light is removed. Now swing the light from eye to eye quickly, but pausing on each eye for around 2 seconds. In the normal patient, the pupils will constrict, then relax a little each time the light is swung to them. Now a patient with a relative afferent defect. The pupils will be equal in size in both light and dark. Both pupils will react to light, although sometimes a slow response is noted when light is shone on the affected side. With the swinging light test, the RAPD now becomes obvious. On the affected side, both pupils dilate when the light is swung across. Here, the left side is affected. You will miss an RAPD if you do not do the swinging light test.
So hopefully that made sense, but let's sort of just talk through it, because it is a very simple addition to a test that you're probably already doing when you check their pupils, but it can give you an immense amount of information, especially if you pick up an abnormality. So just as we said, if you shine a light in the eyes, they both should always be doing the same thing. So if you have a normal person and you're shining a light and you swing it back and forth, honestly, you shouldn't see a ton of movement. Maybe see a little wiggle, but really not much. When you have an APD or an afferent pupillary defect, what happens is, let's say this is the normal, this is the abnormal, okay? So the normal side sees 100% of the light, all the optic nerve fibers are firing, I shine a light over here, both eyes constrict because they're sensing this bright light. When you swing it over to this side that only has 50% working, all of a sudden, this optic nerve registers 50% less light than this side. So it says, oh, they just turned down the lights by 50%. I'd better dilate. And it dilates. But both dilate because the pupils are always working together. So when you swing it to the abnormal side, you see dilation. You go back to the good side, you see constriction. You go back to the bad side and you see dilation. And so the only way you'll ever pick up that there's something wrong with this optic nerve is when you swing it back and forth, because you are trying to see that they are not acting the same. If you knocked 50% out of both optic nerves, you wouldn't be able to pick up anything on this test because it's in comparison to each other. But like I said, when you have an optic nerve issue, usually it's just one side. So this will let you pick that up. And interestingly enough, when you're doing this with a person, and if they're awake and able to talk to you and tell you what they're seeing or not seeing, I always double check myself their perception of the light. So when I'm shining it in the good eye, I say, this is $1 of light, okay? You just paid $1 for this much light. How much would you pay for the light on this side, meaning the abnormal side? And every single time they will give me a cent amount. They will say 75 cents, 50 cents, 10 cents. It's amazing. However, if I say percentages, they can't do it. If I say 100%, how much light is over here? I don't know. But if I say money, they can tell me cents-wise how much cents they'll pay for that light. So it helps you to know that you did see what you think you saw, because they're confirming it in their perception that I'm not seeing as much light on that side as I did on the other side. And when you see an APD, it's only one-sided, so it's going to be a problem with the optic nerve or the retina or something in the eyeball. Okay, that's where it's gonna be. If you see a totally unreactive pupil, like you do your normal checking light reflex and nothing happens, that's unusual. It could be something in the brain, obviously blown pupil. It could be trauma. You know, trauma can sever an optic nerve or can severely damage it. It could be something going on in the eye. They could have had eye surgery and their pupil is just sort of frozen or scarred in place, so it's not moving. But if you see like a really nice blown pupil and they're talking to you normally and you're like, this is not making sense because they're talking to me normally and not unconscious, ask them about eye drops. It could be that they got something in their eye that dilated them. If they were at the eye doctor recently, you will not be surprised at how many calls I've gotten for people saying, my eyes are still dilated, what's wrong with me? And I say, you were just at the doctor 3 hours ago, they haven't worn off yet. Or even if people use like scopolamine patches, they put it behind their ear, they forget to wash their hands and then they rub their eyes, and the scopolamine has a dilating effect and it acts as if you had just put dilating drops in your eyes. And I've had 1 or 2 of those come in freaking out because both eyes are blurry and dilated and they didn't go to the eye doctor. So if it's really dilated and not moving and they're talking to you, it's probably something pharmacologic. So try to get a sense of medications, chemicals, you know, pesticides, anything that they could have gotten in their eye that might be affecting their pupillary function. Okay, intraocular pressure, I threw this in here just for completeness sake. This is a picture of a tonal pen. You're not going to have one of these, I doubt, on your truck. But this is what we use in the clinic and the ER to check pressure. But you can check pressure yourself with your fingers, actually, especially if you are very suspicious that someone has very high pressure. So someone with very high pressure in the eye is going to be in a lot of pain. They're going to be nauseous, ready to rip their eyeballs out. And that might lead you to be concerned about angle closure glaucoma or an attack of angle closure glaucoma. And the easiest way to do it is just to take 2 fingers and very gently over a closed eyelid, you just kind of bounce it. And I encourage you to do this to yourself because then you can see what a normal eye is supposed to feel like. It feels kind of like a ripe grape, right? It's not too firm, but it's not so squishy that it doesn't have a substance to it. And kind of getting the sense of the right consistency is good, because then when you go to touch someone else's and it's very, very hard, you can go, whoa, that is not what an eyeball is supposed to feel like. And most of the time that person has a control on the other side, and you can touch their other eye and say, well, that one felt normal. Why is this one so hard? And that can start, you know, sending red flags that okay, this is probably high pressure, these are the steps I need to follow next. So those are sort of the bits of the like eye exam part. But there's another part of the eye exam that you already started when you walked in and said hello to the patient and started talking to them, and that's inspection. As they're talking to you, you're looking at their eyes, right? Maybe you're looking to see if they have pinpoint pupils. You're looking to see if their eyes are red. Do they have like a bloody, swollen mess? Like what's going on there? You're doing all that while you're starting to talk to them. Don't be palpating the eyeballs. Do it over the eyelid.
Just a reminder, right?
That is true. So, again, these are things that you would notice just looking at the patient. You might see redness and swelling, maybe suggestive of inflammation or infection. This poor guy has a huge rash that goes down over the eyelids into his nose. So that looks like zoster. You can have lacerations, other signs of trauma. These are things you're going to notice just as you come in and kind of start everything. The conjunctiva has findings as well. Here's you got your as standard comes pink eye, right? And this could be a million different things, but it is a finding. They have a pink eye. Here, it's a very bloody eye. Here you have actually, if you look carefully, there's a little area here where it seems like there's fewer blood vessels, and you can almost pick up like the tissue is lifted up. And this is actually a conjunctival laceration. So they've had some sort of trauma and the conjunctiva has been ripped a little bit and there's a little bit of blood in there. And these are all things you can see just examining, just looking at them. Here, this is a nice little metallic foreign body complete with rustring that you can sometimes see with the naked eye. You don't necessarily need to have a slit lamp or a microscope to see something like that. Here's some cornea clouding. Here's one of my many examples of a peaked pupil with some fun intraocular contents that are not supposed to be on the outside, and we'll go into that into more detail. But again, looking at the eye, you're going to come up with different eye findings that are then you can pass along, or you can collect them yourself and start to think about, okay, what could these mean, and what does that mean for me with the next step of the next stage of care for this patient? These are just some specific eye findings that I wanted to make sure you guys had all seen and heard what they were. Chemosis, this is, think of like a blister on your eye. So this is the conjunctiva. This is the thin layer, that thin like a membrane layer that sits on top of the sclera. The sclera is underneath here. And in this case, it's filled with fluid. And this can be from infection, like a pink eye, a viral infection can do it. It could be someone who's fluid overloaded, like a burn patient or someone in the ICU who's getting tons of fluid. In this setting here, instead of being filled with clear fluid, it's filled with blood. So it's called hemorrhagic chemosis. Chemosis meaning the conjunctiva is kind of filled with stuff, and hemorrhagic is when it's filled with blood. A hyphema, this is blood in the front part of the eye, and a hypopion is pus in the front part of the eye. And actually, here you see another, this is a light reflex. This is not. This big white blob is a corneal ulcer. So it's a corneal infection. Let's say they were a contact lens wearer and never took their contacts out, or only took them out once every 6 months or something. So this is a bacterial infection, and this is pus. So it's gotten so bad that their eye is filling up with pus. You can see it's really red and angry. This is not a happy eyeball. And we'll talk about that when we talk about endophthalmitis a little bit. Okay, here's another peaked pupil. You guys are gonna get real sick of peaked pupils by the time we're done. Here, you can actually see a little tuft of kind of blue-green stuff coming out. That's the iris. So here we have a rupture. We have a corneal laceration. Something has broken the eyeball, and the iris has plugged the wound. And as a result, the pupil is turned into a teardrop shape with the point always pointing at the rupture. It's like a little arrow telling you where to go. Here's a cataract. You might notice it when you try to do, let's say you check for reactivity and you look at one side and it looks, you kind of get that little bit of a red reflex before the pupil constricts, and then you look on the other side and it looks kind of whitish. That's a cataract. So you can see the cornea is clear. You can see the iris perfectly well. The lens is here, the pupils, the eye's dilated. That's why the pupils look so big. But that is kind of deeper, and that is a cataract. And compare that to a hazy cornea where everything is kind of fuzzy, right? The iris is fuzzy, the pupil is fuzzy, everything just looks kind of hazy. And that's because the cornea sits in front of everything. So if the cornea is hazy, everything behind it is going to look hazy. Whereas the cataract is a lens that sits behind the iris. So the cornea and the iris should look okay. The cataract is even further back. All right, I'm gonna just pause for a second and ask if anyone has any questions about eye exam, eye findings before we go on to eye emergencies, or anything I can answer at this point.
So many great pearls. I remember the lecture from a couple of years ago. We were together in Essex and already forgot about things like APD and cranial nerve 3 stroke. So yeah, so many great pearls. Thanks. And great pictures.
And hopefully they're a little easier to see this time around.
Right. There's someone in the chat.
Okay, yep, I see. So the question is, can we talk about pupils of people who have had lens implants? I assume that's with reference to cataract surgery when you say lens implants. And most of the time, people who have had cataract surgery, if everything was completely normal, no problems in surgery, their pupils are going to act very normal. They're going to look the same. There might, they might be a slight difference in size, but they're not going to have an APD. They're not going to be unreactive or anything like that. However, if they had a more complicated surgery, or in some cases, I know this sounds barbaric, but we might have to use hooks, little teeny tiny hooks to stretch the pupil because they have a condition that doesn't allow their pupil to dilate as much as we need it to do surgery. They may have a wonky looking pupil, but it's not going to be teardrop shaped. It's going to be like a rhombus or some sort of amorphous thing that doesn't quite have a shape. You might see scar tissue or little holes in the iris. Even people who've had glaucoma surgery or retina surgery, the pupil might be like a little off center. You might see an extra pupil, like a big pupil and a little baby one, but you're not going to see a teardrop. You're not going to see that classically kind of pulled to one section. That happens when the iris, which is a round muscle, I can't make a circle, gets pulled because it's getting stuck in a wound. Nothing else is going to do that short of, I guess if they had surgery and something scarred the pupil to one side, but that is not the majority of the people you're going to see who've had eye surgery or lens surgery. Most of the time, honestly, their pupils are going to be completely normal. You're not going to notice a difference. And when you do notice it, they just look weird. They don't look like a peaked pupil. And their reactivity should be fine unless they had complications that then caused, I don't know, optic nerve damage or something. There was another question about what causes a hazy cornea, and there's a lot of different things that can cause a hazy cornea. A hazy cornea is an unhappy, unhealthy cornea. So after cataract surgery, for example, if we have to use a lot of power, the cornea absorbs that power because we have to break up a very hard lens. The cornea absorbs that power and it's swollen for a week or so, and it looks a little bit hazy. If you have an infection, it can be hazy. If you have very high pressure, that high pressure is affecting blood flow to the cornea and nourishment to the cornea gets unhappy and it can get hazy. So there are several things that can cause a hazy cornea, and we look for other things that might be going on as well. Is there redness? Is there pain? Did they get chemicals in their eye? That can cause a hazy cornea. So there's a lot of different things. So just having a hazy cornea, we then have to, look at what else is going on to try to get a good differential of what's going on. Whoops. There we go. Okay, I'm going to keep going. And if there's any other questions, Sean, please stop me.
Yeah, what causes the haziness of the cornea? Did you just answer that?
I did.
And then the patients with glaucoma or other surgery? Yes,
yep.
That's all normal. That's
okay, great.
Great. Okay, thanks.
Okay. So let's move on to eye emergencies and kind of what you can expect to do with them most of the time. Now, I will say I have a blanket caveat that I'm just going to say now so that I don't have to say it every single time. I am assuming that all else is okay. Okay, I am not going to get into their brain function or their lung function or their heart function or neuro or anything. I'm assuming all of that stuff is normal and we're just talking about an eye issue. Obviously, you need to do what's best for the patient overall, and brain and heart usually trump eyeballs. So, I'm just saying that because I feel like I have to say it once, that the eyes are important, but there are other things that are more important, and you need to use your judgment from that standpoint. Okay, chemical burn. We just mentioned that with the hazy cornea. Chemical burn, the treatment for that is irrigate. So you're going to get a story. I got something in my eye. I splashed bleach in my eye while I was doing laundry. My, kid spilled this and it splashed into my eye. Whatever it is, the first answer, whoever's talking to the person, is irrigate your eye out. Flush water into your eye. And that should be started hopefully before you get there. Once you get there, as soon as someone tells you, oh, I got something in my eye, start flushing it out. Because the treatment for this, really the only treatment, is to flush whatever got into their eye out, because any remaining particles will continue to release the chemical and will continue to cause damage to the eye. And we just need to keep irrigating until the pH gets back down to 7 or to normal. And you can use anything. You can use water, saline, lactated ringers. You don't need a fancy ophthalmic eye drop or anything. You just need something liquid, isotonic. Never try to, fix a base with an acid or an acid with a base. You don't want either of those in the eye. Base is very bad, but you don't want acid in there either. So whatever you're using, make sure it's isotonic. Don't try to neutralize. You want to try to dilute and flush out. In the ER, a lot of times they'll use what's called a Morgan lens. I don't know if you guys have seen this before, but it looks like a big contact lens on one end, and then the other end hooks up to your IV bag or whatever and just drips fluid right on the eye. Not super comfortable, but it's that or go blind. Most people will just sort of take it. I've seen people hook up a nasal cannula and then just have it drip onto the eyes. I personally have used these little flushes. I've used saline bullets, whatever I can get my hands on. If you just have a big bottle of the water, you just take a big syringe, suck up a big amount and squirt it in the eye. You don't want to power wash the eye. So, be careful with that, but you just want to irrigate very well in order to get out all the chemicals. Sorry, make this smaller.
There's a question about covering both eyes or just the injured side.
I will get to that when we talk about globe rupture. If you could just put a pin in that, I promise I'll address that. So base is bad. And base, like I said, both of them are bad, but base is worse. Acid, when it gets into the eye, eventually gets neutralized. It causes its damage and then kind of gets neutralized and stops. It runs out of steam. Base does not. Base continues to digest and actually saponify eye tissue, which means it turns it into soap. So getting base out of the eye is very important. And in both cases, just lots and lots of irrigation is the best way to go. These are some examples of the range of injury you can get from a chemical burn. This first picture is incredibly mild. This person was very lucky. What you're looking at is we put a special dye in the eye. It's a yellow eye drop that you put in the eye. It's called fluorescein. And when you shine a blue light on it, it makes any abnormality on the cornea look green. So if you look closely at your screen, you'll see there's little green speckles. And that is kind of like little tiny abrasions to the cornea from the chemical. Okay, so this case, it's very uncomfortable. I mean, these little speckles actually hurt a lot. So very uncomfortable. However, generally heals pretty well within a few days, lots of irrigation, some ointment, etc. They do really well. This one in the middle is not looking so great. You can see the eye is very red and angry. And actually, it's really hard to see the pupil. I know it's a dark eye, it's a darker eyed person, but usually you can see an iris and a pupil. This one's very hard to see, which suggests that the cornea is getting hazy, because normally you should have a clear view and be able to see stuff on the inside. So the cornea is starting to get hazy. And see, I don't know if you can appreciate, there's a little whitish patch here where it looks like there's fewer blood vessels than, let's say, over here where there's a lot of really big, juicy blood vessels. This looks like an area where the blood vessels are starting to die out. That's also not a good sign. And here, this is the worst possible, chemical injury. And what has happened here, the cornea, this white here is the cornea, not the sclera. This is completely clouded over. So no clarity to it at all. It's completely clouded over. And if you look at the conjunctiva, one thing that you may be surprised to see is that it's white. It's not red and angry. Like, where are all the blood vessels? They're dead. They're destroyed by the chemical. So there is no nutrition going to this cornea. This cornea is starving and it's going to die if treatment, and honestly, even with treatment, there's not a whole lot you can do at this point. But this is the worst case scenario where you're losing blood vessels, your cornea is incredibly hazy, and this eye has got a very, very poor prognosis. Now, there's a question that came up about welder's flash. And a welder's flash is essentially a UV light burn. And it's kind of similar to what would happen if you were to look at the sun for too long. And I have a little funny story. I'm going to take a little digression, something that I personally did to myself that I'm embarrassed to talk about since I'm an ophthalmologist. But if any of you have ever worked in a lab, I was running gels. And when you run a gel, you get a little band of dye or whatever, and you have to cut it out under UV light because you can't see it otherwise. Well, you're supposed to wear these glasses and you put them on a table and the table shines the UV light up through the gel and you look down and you cut it out. And I'd done this all summer. This was in college. And one time I forgot my eye protection. I just went in and did it. And then the entire rest of the day, I couldn't figure out why my eyes were on fire. They were red, they were watering. I could barely keep them open. I thought for sure my mom was gonna think I was high on something because I had to go to my church bingo that night. It was bad. And it took me most of the evening to realize that I had just stared at a UV lamp for like 20 minutes trying to cut out this little piece of agar gel. And somehow I managed not to be permanently blind or have any downstream consequences. But this here is probably what my cornea looked like right afterwards, where you get damage to the outermost layer of the cornea and you get these little speckles. And the treatment is usually ointment, something soothing to help the cornea heal back over. Most of the time, that's what it is. It could be a little bit worse, but it's a, I don't want to say burning off because that sounds a little bit harsh, but it's an abrasion or a disruption of the outermost layer of the cornea from the UV light from the welder's flash. But yes, time, shielding, ointment can help. And usually the cornea actually heals very quickly as long as it has a blood supply and nourishment, etc. Okay, great. So another eye emergency is hyphema. Hyphema, we had a picture of it and I'll show you another one. It's almost always in the setting of blunt trauma. So, and it doesn't need to be disastrous trauma. It can be my kid poked me in the eye. It can be, I got elbowed during a basketball game or something. It doesn't need to be a lot. But what happens is something happens, something hits you in the eye, breaks a blood vessel in the front part of your eye, and that anterior chamber, which is the space between the cornea, this is my iris, and then this is my cornea, that space under the dome is your anterior chamber. And obviously, normally it's clear, so you can see. In a hyphema, it fills up with blood, secondary to the trauma. Not unsurprisingly, your vision will go down because now you're trying to look through blood instead of looking through water. Very difficult to see. And the way we normally talk about it is either in percentages, like how much of the iris is covered, or we might say it in millimeters. There's a 2 millimeter high hyphema, for example, or a 50% hyphema. And the more of the iris that's covered, or the more blood that's in the front of the eye, the worse the prognosis. So if you have 100% hyphema, which means we call it an 8-ball hyphema, it's totally all red, can't see a bit of iris. That's very concerning for a glow rupture. because that's a serious amount of trauma to cause that much blood in the front of the eye. And here are some examples. So here to the left, you've got a little tiny one. Here to the right, you've got about a 50% hyphema. And here in the middle, you've got your apall hyphema. They've got a lot of hemorrhage under the conjunctiva. And this person, I'd be very strongly suspicious for a globe rupture. And if we don't see anything, a lot of times we'll take this person to the OR and look for a rupture if we, excuse me, if we have a high suspicion. To treat this, you put a shield on it. The reason, even if it's a little tiny baby one, you put a shield on it for the reason that they can rebleed very easily. So if in transport, the patient, you know, rubs their eye, because people are always touching their eyes and their face, they can cause enough trauma with just that to cause more of a bleed. And then what you had when you had a little tiny hyphema turns into an even bigger hyphema with a higher risk of consequences. In kids, we'll sometimes put them on bed rest because we just can't trust them to not, you know, run into things or to play rough. In adults, usually it's an eye shield, you know, and then give it some time to go down. If all things are otherwise okay and you can put the head of the bed up a little, like at a 30-degree angle, that will help because that lets the blood settle. So if you think of a snow globe, you know, you shake up the snow globe and everything is floating around. Well, the eye is turned into a snow globe and you've got blood floating around. If you can put the head up at an angle, gravity will help pull that blood down. And maybe by the time you get to the hospital, maybe the patient's vision's gotten a little better, or by the time they see the eye doctor, we can see a little bit through the top and try to get a sense of what's going on. It's better to do that than to lie them flat if possible. In the setting of a hyphema, in the setting of chemical burns, I think I neglected to mention, in chemical burns, ideally you want to send them to a place with ophthalmology or who can get ophthalmology there relatively quickly, especially if it's a bad burn. With a hyphema, if it's okay, it's not super big, doesn't need to necessarily have ophthalmology, but it'd be nice if they had ophthalmology around that they can go see them the next day or something like that. If it's 100% hyphema or a really big one, then you want to take them to someplace that does have ophthalmology in-house. Chemical burns, like I said, oh, wrong way, sorry. So intraocular foreign body, that's the next one. Oh God, I love this question. The question is when to use the Wilmer Eye Institute versus a regular ED. I will tell you, coming from the other side of the city, that using Wilmer Eye Institute is equivalent to using any hospital that has ophthalmology in-house and on call. It does not have to be a special eye ER. Like if you take it to Maryland, if you take it to Sinai, if you take it anywhere that has ophthalmology training and has residents in-house that are going to see the patient right away, use that. A regular ED is, you know, some of the things I mentioned, like a mild chemical burn, a mild hyphema. Those things could go to the regular ER doc, they can evaluate them, and then they can set them up for ophthalmology follow-up as an outpatient. And I will try to, excuse me, I forgot about that. I will try to be better about telling you that with each condition as well. Intraocular foreign body, this is going to have a suggestive history. You know, I was under, my most common is I was working under my car, you know. The textbook is someone was grinding metal. It can be any number of things, but something was going on and then something flew into someone's eye. You may or may not be able to see it. Sometimes you can see, like I showed you in that photo, a little black speck on the front of the eye that when they blink, it doesn't move, or they're blinking and they're saying, oh, I think there's something there. And you kind of just come in and you look and you're like, oh yeah, there's a black thing on your eye. That's an intraocular foreign body. It's embedded in the cornea. It's not necessarily all the way in. Most of the time they don't go all the way in. They just kind of get stuck in the cornea, but there is a chance that they could go in. So ideally, you want to take them somewhere that has ophthalmology in-house, especially if you think it's something large or it has gone all the way in. If it's a little tiny speck sitting on the surface, you could probably take that to a regular ED, and then they could have them set up with ophthalmology follow-up after that. It also kind of depends on what the thing is. You know, if it's a car accident and it's a little bit of glass, may not be so bad. Glass doesn't really react too much. Iron is steel is the more of what we see. It's pretty bad, but usually it's pretty bad if it's a big piece and it's in the eye. If it's a tiny little piece and it's in the front of the eye, we can usually flick it out with a Q-tip or actually the tip of a needle, and they do fine. Really bad is going to be like organic material, wood, you know, something from a farm, you know, something very dirty and is going to have other stuff because it's organic. Those can lead to really bad infections very, very quickly. So those need to be taken care of. Sometimes they need to go to the OR right away to clean things out before the infections can take hold. And do not try to remove in the field. I know it goes without saying, but I just have to say that. Okay. I see that there's a few questions here. Yeah. I will touch on the ruptured globe question in a second. Flushing the eyes with milk in the presence of pepper spray. I have no problem with you putting milk in the eyes. Milk is pretty neutral. If you don't have water or if you're concerned that water, I haven't really heard of anyone doing that, honestly. I also haven't heard any downsides of that. So if you would like, I can look into that specific example and get back to you all through Sean. But I don't personally anticipate a problem with that. Yes, ideally you should be irrigating these eyes during transport because unless you have pH paper and you are able to check the pH of the eye in your ambulance, then you shouldn't really stop until the pH gets to 7, and you're not going to know when that is. And you don't know how much the patient irrigated before you got there. And you don't know how well they were doing it. You know, like, was it just running down their face and not getting into their eyes because they had their eyes closed the whole time? So when you're doing it, you know you're doing it right. And, you know that you're getting it for a decent amount of time. At least, I don't know, let's say it takes you 15 minutes to get to the hospital. You know you've done it for at least 15 minutes. So when you get to the ER, they can check the pH. And if it's still high or low, you know, they can continue the irrigation. But you don't want to delay treatment, which is irrigation, to get to the next level of care. And I haven't forgotten the globe rupture question. I will get to it. So these are some images. So this is a very large intraocular foreign body. So that one you would not touch. You would take that to somewhere with ophthalmology, and you'd probably put a big eye shield on that to make sure that nothing else touches it. Here is a CT scan. You can actually see a little foreign body that got into the eye. And here is an eye exam. So this is us looking through the pupil. This is the optic nerve. It looks kind of fuzzy because there's a lot of blood floating around in here. And then you've got this metallic foreign body floating around inside the eye. And here's another peaked pupil. And in the setting of, I was under my car grinding metal, I felt like something went in, and then you see this. This is your site of entry right there. Okay, you've got the peak of the pupil pointing to it, little bit of blood. I would take this person to somewhere with ophthalmology because there's potentially a foreign body inside the eye and they have a peaked pupil. This is not something I would take to a standard ED. Okay, ruptured globe. Ruptured globe is an emergency. A ruptured globe is any time the integrity of the eye is damaged. So it can be a puncture, a one-sided wound, or it can be a penetration. It can be all the way through. Either way, when you crack open the eyeball, bad stuff can happen. It can get infected. Stuff that's on the inside can come out where it's not supposed to be. And you can have serious downstream vision issues depending on what's going on. So what are some signs of a globe rupture? Well, you've got the obvious here. You've got stuff coming out that shouldn't be there. Even if someone has blue eyes, you're usually going to see brownish stuff coming out. So in the setting of trauma, if you see brownish stuff sitting on the eyeball, don't wipe it away. It's probably intraocular contents. Just put a shield on it and leave it alone. Okay, any brownish stuff that's sitting on the eyeball is most likely eye guts. You're going to look for a lot of hemorrhagic chemosis. That means there's been a lot of trauma to the eye. That means there's bleeding under the conjunctiva, which could be from a rupture in the sclera or a rupture in the back of the eye, and that blood is coming forward. So this eye, you don't see anything like coming out, obviously, but they've got 100% hyphema 360 degrees of hemorrhagic chemosis, this person I'm taking to the OR to look for that rupture because there's probably a rupture there. It's most important that you do not apply pressure to the eye, because any pressure you or the patient applies to the eye is going to cause more of the stuff on the inside to come out. The peaked pupil is your friend when it comes to anterior ruptures. So anything that's going to rupture the eye in the front, so from the cornea, around the cornea, the pupil will point it to you. Will say, here, look at me, this is here, this is bad. Stop, just put a shield on and you're done. And you can see different degrees of it, and hopefully you can appreciate the physics of why this is happening, that the iris is getting stuck in whatever that new hole is that's not supposed to be there, and it's causing this peaked pupil, and every time it's pointing at the rupture. The treatment, place a shield, okay? If you have any concern that they might be getting nauseous and are able to give them antiemetics, do so, because if they start to valsalva and they start to throw up, they can actually increase the pressure in the eye and force more contents to come out. So we want to try to keep them calm, keep them relaxed, take them to a hospital with Ophtho in-house that can, take them to the OR. We like to take them to the OR usually within 24 hours to prevent infections whenever feasible. Again, all other things being stable. Now, there was a question about covering one eye or covering both eyes. And every time I'm lecturing EMS people, this question comes up. And before every single one of these lectures, I have asked multiple ophthalmologists, and not one has ever heard or read or done the patching of both sides. I have talked to people in the midst of globe rupture. I have seen them move their eyes around. I don't see it causing any worse injury. You have to think of it from the perspective of the patient. They are freaking out. You maybe just told them that their eye is busted. They've been in a terrible trauma. You're covering the eye that they can't see out of anyway. Okay, but then you go ahead and cover the eye that they can see out of. Now they are essentially blinded. They don't know what's going on. You are touching them and poking them and prodding them and taping things, and they are freaking out even more. So moving the eye does not make a globe rupture worse, and they can still move the eye under the shield. So just because you don't see it doesn't mean they're not moving. They're probably rolling around their eyes in complete freaking out craziness under that shield that you can't see. So I personally would not recommend shielding both. Only shield the eye that's injured. And I think that would help both the patient and you keep the situation under control. There was another question about globe rupture. Will a patient with a ruptured globe be completely blind in that eye? And the answer depends on the level of the rupture. So if you have someone with this teeny tiny rupture, they are not likely to be blind from that. That will hopefully be a very small surgery. We go in there and we just pull the iris out of that wound and put a stitch in and close that up. And if all the other stuff on the inside has remained where it's supposed to be, this person will do fine. And actually for these two as well, they probably have a very good chance of doing okay, provided that the stuff in the back is all right. If this is the only injury, maybe they have a wonky pupil for the rest of their life, but we can save their vision. If you have someone like this, or actually in this situation as well, the rupture in this one is a little bit more extensive. And in this case, the rupture is likely very far back, so close to the optic nerve. So I've had ruptures where I've had to go all the way back to the point where I can see a big slit in the sclera and I can't get far enough back to finish closing it up. It remains open because I just can't physically get there. I've seen ruptures where they're filleted open like a flowers of a petal flowers, where they just have so many, usually that's like a gunshot, where they just have so many things. And I try to put it back together, but it's like putting a puzzle together and not having all the pieces. So the worse the rupture, the worse the prognosis and the higher the chance that they're going to be blind afterwards. But not every rupture will give you a blind eye. It just depends on the extent, the extent of the injury. This person has high levels of ammonia. Not not to my knowledge, will there be evidence of ammonia in the conjunctiva. If they have a lot of liver disease, like jaundice, you will get yellowing of the sclera in the conjunctiva, if that's what you're referring to. And does this including penetrating objects covering both eyes? I mean, are you, if you're talking about like a spike sticking out of someone's someone's eyeball, I'm not quite sure what Shell Ports was referring to with regards to the penetrating object. Glued eyelids, I've had that. Unfortunately, I had that in a little kid who got a hold of his mom's, what do you call it, lash extension glue, and managed to glue his eyelids shut. That is stressful, but it's not damaging to the eye. So cyanoacrylate is actually a glue that we use on the cornea when we have to use glue during cornea surgery. So it doesn't hurt the eye, but when you glue your lashes shut, it's really hard to open. So a lot of times what we have to do is cut the lashes. And I have sat there and meticulously tried to, you know, peel pieces apart. And if I can't, we just give it time. You know, just like super glue on your skin eventually kind of comes off. And as long as it's not very rough, if it's very rough, like there's a big blob on the cornea, we might put a special contact lens that acts like a shield just to protect the eye and the eyelids until it can come off itself. Protocol states cover both eyes in penetrating traumas like a pencil stuck in the eye. Again, the concern I have is that covering both eyes does not prevent them from moving their eyes around. They are still just as likely to move their eyes around, and you are going to freak them out. And if they have a pencil stuck in the eye, I'm not sure how you're going to get the shield on it as well. But, you know, that's just my feeling and what I've seen in the ophthalmology literature. I looked extensively and I've spoken to many ophthalmologists, and I just have not seen any indications to cover both eyes. Okay. Any other questions about ruptured globe? I think I've beaten the peaked pupil to death. I hope if any of you see a peaked pupil, you'll think of me and and are happy that you know what to do with it.
There was another question. If blinded, can an eye replacement be done, or is it just the cornea that can be replaced?
Oh, I missed that one. Unfortunately, no. There's no, we aren't at the point where we can really replace eyes or do an eye transplant. I'm usually the person they call when an eye has gotten to the point where it has to be removed, and there's no way to put anything else in that place. Having said that, just having one eye is not the end of the world in terms of function. You can still do just about everything. You can still drive. You can't fly a plane, but you know, you can still do a lot of things with just one eye. Your depth perception is a little bit off because you no longer have two to give you stereo vision, but your brain is surprisingly malleable and readjusts and uses other clues to pick up on depth. You can replace a cornea, so you can do a corneal transplant, and they'll do that in certain conditions. But we haven't gotten to the point where an eye transplant is feasible yet, unfortunately. Okay, angle closure glaucoma is one of the few eye emergencies that is really timely. In terms of what we say time is eye. So the longer you wait, the more eye damage there is, and the worse the prognosis is. So when you have angle closure glaucoma, what usually happens is it's just a function of how your eye was made, you know, how it was when you were born. You have narrow channels that allow the fluid in your eye, which is constantly circulating, to drain. It's not necessarily anything someone does to themselves, it's just their anatomy. And what happens is something happens to cause those narrow channels to close off. And when that happens, the fluid can no longer drain well, and it just starts to build up, and so the pressure spikes. Normal eye pressure is from 10 to 20 usually. Anything higher than that, you know, we'll say 20 to 30 would be like your grandma's glaucoma that you think of, or, you know, the kind that where people take drops for their whole lives, is usually in the 20 to 30 range. acute angle closure glaucoma, that's going to be 40, 50, 60. That is a huge rise in pressure, and it's very sudden. The other kind of glaucoma that you hear about is typically very slow. It's kind of like blood pressure. Like, it's one of those things where you don't feel, but it just gradually causes damage over time. This one is very quick. You feel it. You are eager to get rid of this eyeball as fast as possible because it hurts so much. You have a terrible headache, blurry vision, and you can see the cornea is very steamy, is very hazy because of the pressure buildup. A lot of times the pupil will get fixed and dilate, like kind of a mid-dilated pupil. It just can't move. One thing that, if they're awake and able to talk to you, which they usually are, is if they look at the lights, like the lights in the ceiling or at your pen light, they see rainbows, like a rainbow halo around them. And that's from the high pressure, that's from the steamy cornea causing these weird visual things. And that's very suggestive of an angle closure glaucoma. They are very nauseous. You know, I've seen ones where they have the trash can next to them in the ED. By the time I get there, they've already thrown up 3 times from the pressure in their eye. And if you were to, again, touch it over their eyelid, you would feel that it's harder than normal. So this is an emergency because we need to get that pressure down fast, because the longer that pressure stays high, the more damage it's going to cause to the optic nerve. And remember, optic nerve is an extension of the brain. So once we lose those cells, it can't bring them back. So it's important that they get treated right away. And I'm glad you asked that question, Koos Hamburger. The protocols suggest caution with the use of diphenhydramine. And this is the kind of glaucoma that they're talking about. They're talking about people with narrow angle glaucoma. Any of those drug inserts that say, be careful of people with glaucoma, et cetera, it's because of this. And what happens is people with narrow angles or narrow drainage channels that can lead to this kind of glaucoma are very sensitive to their pupil dilating. And so certain medications will cause their pupils to dilate, and sometimes it can push the iris forward a little bit, and that's enough to just close off that channel and lead to an attack of angle closure glaucoma. So that's why certain medications will cause this, or they'll have that warning of, be careful if you take glaucoma, talk to your doctor first. It's if you have this kind of glaucoma, not the, I need to take drops for the rest of my life because, you know, I've got this very slow, open angle glaucoma. Did that answer your question about the diphenhydramine? Hopefully. Okay, great. This weird like delay, it's odd. Okay, I promised you some more gross pictures. So here's endophthalmitis. This is, remember, this is the eye that's full of pus. And I am not exaggerating when I have said there are eyes that are full of pus. I mean, you see the pus in the front, there's pus in the back too, in that vitreous cavity, and where at times where we have to go in surgically and suck it out because there's no way the body's going to be able to reabsorb all of that infectious material. If you look closely at this picture, I hope you notice that there's some weirdness going on in addition to the hazy cornea and the hypopion, the pus. You may see some little black lines here, little figure 8s there, kind of look like an hourglass. Those are ophthalmology sutures. So this person had eye surgery recently. And history of eye surgery or history of trauma are 2 big risk factors for endophthalmitis. Basically, anytime you're going to open the eye, you run the risk that it's going to get an infection because it's normally a very secluded, closed system. Bugs have a hard time getting in it. But, you know, when you do surgery or you have a severe trauma to the eye, well, now you've opened a pathway. You can imagine their vision is not very good. They're in a lot of pain. The eye is very red, angry, they're unhappy. And the classic finding is you see the hypopion, the collection of pus on the inside. This is an emergency because it needs ophthalmologic treatment right away. And unfortunately, this is not something that's going to get better with eye drops. The eye drops and IV antibiotics don't penetrate into the eye enough to kill the infection. So we actually have to do intraocular injections, which is as bad as it sounds. We stick a needle in the eye and squirt antibiotics directly into the eye. And that's the only thing we can do really to save the eye. Sometimes we take them to surgery and kind of rinse out the crap that's on the inside, the pus and everything, and then dilute it, flush it out with good stuff, and then put antibiotics in that way. But there's no other way to treat it. So this really needs ophthalmologic care, and it needs it quickly, not as fast as an acute angle closure where we're talking on hours and minutes. But this is something that needs to be done sooner rather than later, fairly urgently, or else as this infection gets worse, it's going to be a lot harder to treat. Like I said, typically this is a history of trauma or eye surgery. However, I have had several cases of endogenous endophthalmitis, which we see in IV drug abusers. So just like they can get endocarditis and other infections internally without necessarily, and I don't want to say no external wounds, because the IV drug abuse is a kind of a wound, but not an eye trauma necessarily. For whatever reason, they can also get this endophthalmitis without having a history of trauma or eye surgery. So one thing you could ask if you suspect that is if they are an IV drug abuser, or if you see signs of that when you go to see them. Orbital cellulitis, this, similar to cellulitis that you would find elsewhere, it's just this is in the orbit, so the eye socket and the tissues around the eye. Here is a CT scan. Here are the bones of the orbit, here and here. And you can see all this soft tissue swelling. This side is relatively normal. So all of this is abnormal. You can see the lid looks puffy. The muscle looks puffy. Here's the optic nerve. You can barely see it. It's probably swollen as well. And this happens, this can happen, by itself. Most often it happens from sinusitis. So if you look at this person's sinuses here, they got schmutz in their sinus. And what happens is those bacteria can kind of poke through the very thin walls of the sinuses here and get into the eye socket. And then they affect the eye socket. You get a lot of swelling. You can see here, he has chemosis, this kid. A lot of eyelid swelling. He can't open it. His eye has to be elevated. You can see his eyes are not aligned because all that swelling is pushing the eye forward. It's pushing it, away from the swelling because the swelling is taking up so much room in the eye socket. He probably has pain when he tries to look around because that muscle is inflamed and it's just surrounded by all this infectious stuff. He may have an APD, but the other thing is they look sick. It's not someone who's just going to have an isolated, I don't know, I woke up and my eye's swollen, so I called you. It's going to be someone who's also probably febrile, looks like crap and has this eye thing. It's not generally going to be a healthy person with only a swollen eyelid. Let's see. Question was, speak to the preference, the use of pain meds for eye pain. All we've got is fentanyl, ketamine, acetaminophen, ketorolac. Concerns. I have no concerns. The only thing I would say is I would not use ketamine in the setting of a globe rupture because succinyl and ketamine can cause the intraocular contents to come out. So I would avoid those in a globe rupture, but otherwise, fentanyl, acetaminophen, ketorolac, I don't have any preference, whatever you can do. I haven't found personally, I haven't found that pain meds do a lot for eye pain. So for instance, if that angle closure glaucoma, that person is in pain from the pressure, the narcotics, they don't help a ton. I mean, I'm not saying don't give it, go ahead and try, but I personally have not found that pain medications help a lot with pain coming from the eyeball. Now, orbital cellulitis, and they're in pain, and it's all the soft tissues and the muscles and everything. Yes, it's probably going to be more helpful. I just haven't found that anything that comes from pain inside the eye that pain meds do a whole lot, to be honest. Okay, so a lid laceration, we're going to talk about a couple different lid lacerations here. Most of them can go to the regular ED. If it's up here in the eyebrow or even in the eyelid that kind of goes, parallel to this crease here, like this, like that, that can all go to the ED doc and, they can repair it. It's when it goes through the margin. So the margin is the end of the eyelid here where the eyelashes are, where it touches the eye. If you cut that, you are cutting the structural part of the eyelid. And if that's not repaired properly, i.e. by Ophtho, they can have a lot of issues with their eyelids and with protecting their eye down the line. So anything that involves the lid margin needs to go to ophthalmology to be repaired. And usually we try to repair it relatively quickly within the first, ideally first 24 hours. I've repaired these at the bedside in the middle of the night. It just depends on, what's going on.
There are a couple of other questions. One, I think we may have, I don't know if we talked about, how do we know who has in-house ophtho?
I would say that any of the larger institutions are going to have in-house ophtho. So Wilmer is going to have in-house ophtho. Maryland is going to have in-house ophtho. Sinai has in-house ophtho. I don't know of any other place in the Baltimore County area that does, to be honest. I mean, I guess if you call the ER, and ask, but I would assume if it's not one of those three places that has residents or fellows or honestly attendings that plan on coming in when they're on call, that they're going to get a little bit of the runaround, and they may be better to guide you. But I think it's just those three. If someone here knows differently, I'm happy to be corrected.
And then there's I would think it's predominantly the trauma centers as well. Is there a numbing drop we can put in the eye that will lessen the pain?
Yeah. So tetracaine and topical proparacaine are the two big ones that we use. They will help. They hurt like hell when you first put them in. I mean, they sting, but the stinging lasts for like 10 seconds. I mean, I'm not talking intense pain, but that does help. They last about 15 minutes. They don't last forever, but they can definitely help with certain things like a corneal abrasion. They're not going to help with angle closure. I wouldn't put anything in the eye of someone with a globe rupture, nothing, like no drops or ointments or anything. But I mean, you could always give it a try with an angle closure person, with someone with an eyelid lack, or even a foreign body that you can tell it's kind of stuck on the outside. You could do a drop just to sort of get them calm and comfortable till you get them to the ED. That would be fine. What I would say is just don't let them pocket it, especially if, I've had patients that come into the ED and it's like a corneal ulcer and it's really painful, and you put a drop of this stuff, and after the stinging subsides, they feel great, like the pain is significantly better because now their cornea is numb. And I've seen them like pocket it and think, oh, I'm just going to take this home. It's going to make me feel better, not trying to be malicious, but hey, this is like the magic drop that's going to fix my eye. And then they come back with a totally different kind of corneal ulcer because they were abusing topical anesthetics, and now they have a neurotrophic cornea where, just like diabetics that can't feel their feet, now they can't feel their cornea, and they have a whole host of other problems. So just be careful. Use it as you see fit. Just be careful to keep it with you because sometimes people will think like, oh, this is a great thing. I should take this home with me. Okay, so I think I got all the questions now. So back to the marginal lid lac, just send it to someplace with ophtho. Canalicular laceration is a special kind of eyelid laceration. And I did not talk about lacrimal system anatomy before. I'm just going to briefly touch on it here. You've all looked in the mirror, you've all looked closely at your eyes, and you hopefully have all noticed that there's a little tiny hole here towards your nose on the bottom, and there's another one similarly on the top. Those are like the drains to your sink, okay? That's the start of the tear drainage system. Your eyes are constantly making tears. They need someplace to go. When you cry, you overwhelm the drainage system and they go down the outside. But under normal circumstances, they go down the inside drainage system, which goes under the skin and then drains into the nose, which is why if your eye's watering, your nose, you're also sniffly because the stuff is dripping into your nose. So that's the normal situation. And this image here, you see someone inserting a stent, but you don't see the end of the stent because the rest of the system is normal. This is one of my patients who had a trauma, and I put a stent in there and the other side popped right out. And what that means is there's a cut right here after the punctum, and the whole tear duct system has been cut open. And what I have to do, or what an ophthalmologist has to do, is reconnect that broken canal. If we don't reconnect it properly, they will not have a drainage system and they will have tearing for the rest of their life, which can be very annoying for people. So if you see a laceration that's very close to the nose, and if you can look and see that little hole and see that it's on the wrong side of that laceration, that needs to go definitely to someplace with ophthalmology, because that's going to need actually OR, most likely OR repair. Sometimes we can repair it at the bedside, depending on the extent. Other times we need to go to the operating room to repair it. But this is not something an ED doc can fix. So think of it like a laceration that's on the eyelid, but really close to the nose. You know, if you see that, you know, try to get it to something with Ophtho, and you can just say, I think it might involve the tear drainage system. Okay, retrobulbar hemorrhage is another one of the eye emergencies that is timely. There's not very many. One of the reasons I picked this field, but this is one that is, again, time is eye. So the longer this person doesn't get care, the more damage is going to happen to their optic nerve, and the more likely they're going to end up with permanent blindness. So what you're seeing in this picture is this person has 360 degrees of hemorrhagic chemosis. They do not have a hyphema. I can see their iris, I can see their pupil fine. They don't have anything going on the inside. This is on the outside of the eye. And what's happening is, if you look again at the optic nerve, at the orbit, it looks kind of like an ice cream cone, and the eyeball is the scoop at the top. And what's happening is some trauma, obviously, a trauma has occurred, and the orbit, the ice cream cone, is starting to fill up with blood. And when that ice cream cone fills up with blood, several things are going to happen. One, the ice cream scoop or the eyeball is going to get pushed forward, because the walls of the orbit are firm. They are bone. They have no place to go. They cannot move. They cannot bend. So when blood fills it up, the only way the eye has to move is out. And you can see that here in the CT scan. This eye is out further than this one. The other thing is, if you look all the way back here, you can see these 3 white dots, and then you see kind of this little bit of white, and then there's a little bit of gray in between. That little bit of gray, that teeny tiny space, is the optic canal. That is the only space the optic nerve has to get from the eyeball to the brain. If that space gets filled with blood, you start strangulating the optic nerve and you get ischemia. So this is essentially a compartment syndrome of the eye socket. And what is happening is blood is filling it up. It's crushing the optic nerve. It's causing ischemia. And the longer you wait, you've got about 90 minutes. After 90 minutes, you start getting permanent nerve loss, which translates to permanent vision loss. So this is filling up with blood, and it needs to be released immediately. The way we release it is actually by cutting these connections up here. So we don't cut the eye. It's just skin and muscle. It's just little bits of the eyelid here. It's a very simple cut. It's a very simple procedure. And what it does is it just makes a little bit of room, enough for the optic nerve to breathe. And so it doesn't die, it doesn't get ischemic. This procedure can be performed by any ER doc. They are trained to do it, and I know that because I help train them. It is part of their residency training. Do they like to do it? Absolutely not. Have they done tons of them? Absolutely not. I've met ones that have never done one in their career. I've met ones that have maybe done one in 40 years. So it's not something they love to do. How do you know that you have a patient with a retrobulbar hemorrhage? They're going to have pain if they're awake. They're going to have decreased vision. The ptosis, the eye bulging forward, you're going to see that. But one of the easiest signs to know as to whether or not they have this is to do a test called resistance to retropulsion. So again, if you take your hands and you just gently bounce your eye, you know that you can feel that your eye moves in like a front to back motion. There's some space there. Well, you can imagine if you have a gigantic blood clot behind that eyeball and you try to push on it, you're going to get resistance. There's something pushing back at you that is not allowing the eye to bounce. That is called resistance to retropulsion. And that is a sign of a retrobulbar hemorrhage. That is one of the signs that I tell the ED docs. If you see that person has a retrobulbar hemorrhage and you need to do the procedure, you do not need a CAT scan. You do not need to check pressures with the tonopen and try to track it down for the next hour. You do not need to call ophthalmology and wait 4 hours for someone to come in. They need the procedure now. So this is something that you need to take it to the closest ED that can manage this. Now, what does that mean? Well, if everything else is totally equal and you've got option A and option B, and option A and B are exactly the same distance from you, and option A has Ophtho, take them to option A. However, if the only option with Ophtho is 4 hours away, they need to go to the closest ED, and you get the ER doc on the phone and you say, you know what, pull up Google, pull up YouTube, you need to do this procedure because this is what I think is going on. And it's something that ideally should go to Ophtho just because we do it more often, we know how to do it, and we're comfortable with it. But I have seen people go blind because of a delay. And the delay, once that happens, I can't go back and fix it. I can't go back and bring the dead nerve cells back. So it's really important that they get the treatment as soon as possible by whoever can do it the fastest. All right. Orbital trauma. This is a soft emergency because a lot of times these don't need to be repaired immediately. Usually you're picking them up and taking them somewhere for an emergency. They probably have more than just an orbital trauma. They probably have other stuff going on. But, you know, this could happen from something as simple as, you know, I get a surprising lot of these, you know, a softball game or something. Someone gets hit with the softball. And what they do is they blow out the bone in the eye socket from the impact of the ball. And what you'll see on exam is some of the stuff we already talked about with the eye not moving well. They might have pain. You might see bruising and swelling. And one fun finding that, if you remember to check it, is they actually will have numbness on that side of the face because the nerve, the V2 nerve that innervates kind of your cheeks here, the canal for that is right in the orbital floor. So if they have an orbital floor fracture and you test both sides, it will feel numb or more numb on the side with the fracture than the other one. And in addition, when you do your extraocular motion, you may see, depending on the extent of fracture, that they have double vision or they have pain with eye movement. And here's an example of a floor fracture. And this is the inferior rectus muscle. So that's the muscle that helps you to look down. And it's stuck here in the fracture. So you can imagine if you were to ask this person to look up, they can't. They can't pull their eye up because there's a muscle dragging them down and it's stuck. It's tethering them down. In this case, the whole floor has kind of just collapsed down. And here's the muscle taking it with it. You might actually see the eye look like it's sunken downwards, depending on the extent of the fracture here. Now, if you are testing them, you'll see this again. Remember, trying to look up and unable to look up on the side with the trauma. If you happen to be doing this test and you already have them hooked up to all the sensors and whatnot, and you see their heart rate tank, just have them relax their eyes. Because what happens is you get a oculocardiac reflex. When you pull on a muscle, like because the muscle's stuck in the bone, and they look up, their heart rate can tank. They get bradycardic. But once you just have them, okay, never mind, go back to regular or look down or whatever, the heart rate goes back to normal. And so if that's happening, that's an important finding for us as surgeons, because that means that person's inferior rectus muscle is entrapped in the fracture, and we need to repair that sooner, urgently, because otherwise that muscle could get ischemic and die, and then they will have permanent movement. Other than that, if you want to try to figure out, what do I do with this person? They have an orbital fracture, where do they go? They can actually go to any hospital that's going to have any kind of facial trauma surgery. So plastics, ENT, ophthalmology, all of even OMFS, all of those services can fix an orbital trauma. And honestly, most of the time, we don't fix it right away. We usually wait, a couple days or even a week. I used to wait a week to see, once the swelling goes down, do they even need surgery? Because sometimes once the swelling goes down, all their symptoms are gone, and then the bone will just heal. However, if they're in a situation where every time they look up, their heart tanks, that is an indication where they might need surgery sooner. But again, it could be done by any number of services. Eyeball popped out of socket in severe trauma. Put it back. Best practice. Boy, you guys are really interesting with the questions today. Okay, so I have had one eyeball that popped out of the socket in the setting of trauma. but it brought its optic nerve with it. So I could not put it back in the socket because it essentially was completely severed and it was hanging on by a little strip of muscle. However, there is such a thing as globe prolapse, and I've seen it more in people that have very bulgy eyes, like kind of big eyes in general, or people with thyroid disease. I have another little funny story, bear with me. When I was a first-year ophthalmology resident, I never wore contacts. I didn't know how to teach anybody how to put in contacts, but obviously I need to know how to do that. And I was helping a lady. I was sitting on the side, I was helping the patient, and then my attending was standing on the other side. And she was lifting her eyelids apart to, put the contact lens in, and her eyeball came out. Like it just came forward and her lids went behind it. And I just froze and looked at my attending in pure terror because it was my first month of residency. I didn't know the eyeball could do that. And I had no idea what to do. And what he did was he had totally, oh, no problem here, look at me. And he went boop, and he pushed it right back in. And I have had the experience one time when I was at the hairdresser where that happened to one of the other clients. And I hear screaming, and they knew I was an eye doctor, and they said, "You have to come. We have an eye emergency." And I was like, "I'm at the hairdresser. Did you get chemicals in the eye? Did someone get a curling iron burn? What's going on?" And I saw this, I calmed the lady down and just pushed it right back in. And what happens is some people have very loose tissues around the eye. The eyelids can actually, if this is your eyeball and your lid, they can get stuck behind it. And what you need to do is you just need to separate the eyeball and gently separate the eyelids and gently push the eyeball back in, and the lids kind of go back around. That is not the same as a setting of trauma. Usually when it's traumatic, there has been a lot of damage that has happened, i.e. things have been severed or ruptured, and those I've never been able to put back in. So I can't answer about best practice, but every now and then I do get a good eye story. Okay, in the home stretch, take home points. Be familiar, be comfortable examining people's eyes. They are vulnerable. They are looking to you to help them out. They don't know what's going on. Having the confidence that you're not going to hurt anybody, you're not going to hurt their eyes. You're just there to help, and get the information you need so that you can make sure they get to the next point that they need to be at. Remember that eye exams can tell you about intracranial abnormalities. So if you see something that's affecting both eyes, you need to think about a brain problem and then triage them accordingly. Any chemical burns, irrigate, irrigate, irrigate. Forget the eye exam, forget checking pupils. They said they got splashed a chemical in their eye. You take them to the sink or you get them set up and you just start irrigating as fast as possible. And as I said, most ED docs can handle a lot of eye trauma. Your hyphemas, your mild hyphemas, your corneal abrasions, orbital fractures, any cuts that don't involve the edges of the eyelid, the margin, the ER doc can take care of it. If you have more severe ocular trauma, ideally you want to go to a trauma center that has ophthalmology in-house. Those are going to be your ruptured globes, your marginal neglects, and again, that caveat about a retrobulbar hemorrhage, in that you can theoretically take it anywhere, but Ophtho is more comfortable doing it, but it should never be at the expense of time, okay? I think that's my last slide. Great, so I will open it up to any questions, either about the talk or any eye questions you've always wanted to know. I'm here for you. Please let me know. And thank you everyone for your attention and your questions. This is my first, live virtual lecture, and it's been really fun.
It's so fun, right?
Thank you for all the kind comments.
Well, thanks everyone. I don't forget, we put the sign in the chat. Make sure that you take a look at the chat. I just sent it out again. Risha, thank you so much. Thanks for presenting all that. What a ton of amazing and great information peppered with great stories.
My pleasure. Thank you, everybody. And
Thank
have a good evening.
Thanks so much. Be well.
Bye.